partners. Good afternoon, distinguished guests, partners, speakers, and young people joining us in person and online. Welcome to our International Youth Day Dialogue. We are coming to you live from the Society of AIDS in Africa, headquarters here in Accra, Ghana. The theme for today's discussion is Different Contexts, Common Aspirations, Rethinking Prevention for Africa's Youth. We will have a presentation by Professor Morenike Oluwatoyin Folayan, followed by a studio discussion with Dr. Nana Kwame Antwi and Ms. Shamima Dakila, and then a question and answer session with all our speakers. Society for AIDS in Africa stands for the Society for AIDS in Africa. It is a Pan-African membership organization that brings together health professionals, researchers, communities, and partners to strengthen Africa's response to HIV and AIDS through science, advocacy, and collaboration. I am Dr. Cynthia Odeya, a medical doctor with a master's in public health, and I will be your host today. This session is being broadcast in English and French. Please go to the chat box and follow the instructions to choose your preferred language. With me online today is Professor Morenike Oluwatoyin Folayan, a member of the SAR board, and Mr. Luke Armand Bodea, the ICASA director and SAR coordinator. With me here in the studio is Dr. Nana Antwi and Ms. Shamima Dakla. To formally open today's program, I invite Mr. Luke Armand Bodea to deliver the opening remarks. Mr. Bodea, you have the floor.
Muted.
You're muted, sir. You're muted, sir.
Oh, thank you, Bob. Good afternoon, distinguished guests, partner speakers, colleagues, and most importantly, young people joining us from Africa and from around the world. On behalf of the Society for AIDS in Africa, it is my great pleasure and privilege to welcome you to this International Youth Day dialogue under the theme Different Contexts, Common Aspirations, Rethinking Prevention for Africa's Youth. Today, we are not simply here to talk about young people. We are here to listen to them, to learn from them, and to reflect honestly on what we as leaders are doing to create the future they deserve. Africa is the youngest continent in the world. Nearly 60% of Africa's population is under the age of 25. And as we look forward to 2050, more than 1 in 3 young people aged between 15 to 24 worldwide is expected to be an African. This is not simply a demographic statistic. It is Africa's greatest opportunity and perhaps our greatest responsibility. The future of Africa will be determined by what we do today for and with our young people. Allow me for a moment to speak about modern Africa. Africa is vast. Its land mass is larger than China. It's larger than the United States and Europe individually. It possesses extraordinary agricultural potential, enormous natural resources, critical minerals, energy resources, biodiversity, and above all, an extraordinary human resources. This is people. Africa holds roughly 60% of the world's uncultivated arable land. Our continent is richly endowed with gold, diamonds, cobalt, copper, oil, gas, and many of the critical minerals that the modern world needs for technology, energy, and industry. Our continent is richly endowed with gold, diamond, cobalt, copper, oil, gas, and many of the critical minerals that the modern world needs for technology, energy, and industry. But let us be honest with ourselves. Africa's greatest resource is not gold, it is not oil, it is not diamond, it is not cobalt. Africa's greatest resource, it is people. And Africa's greatest people are its young people. And yet, despite this extraordinary wealth and potential, millions of young Africans still struggle to access quality education, practical skill, decent employment, security, social protection, and essential healthcare. This is a contradiction we must confront. How can a continent so rich in land, resources, and human potential have young people who feel that their best chance for a future lies somewhere else? How can we accept that a young African may look across the sea and see more hope than he or she sees at home? How can we accept that some young people are prepared to cross deserts, face traffickers, risk imprisonment, cross dangerous seas, and even risk death in search of dignity, opportunity, and a better life? They are no merely migration questions. These are no merely migration questions. They are questions about development. They are questions about leadership. They are questions about dignity. And ultimately, they are questions about prevention. The Central Mediterranean remains one of the world's deadly migration routes. The International Organization of Migration has documented thousands of migrant deaths and disappearances along these routes, including more than 15,000 deaths since 2014. Behind every number is a human being, a son, a daughter, a brother, a sister, a friend. And behind every person who disappears is a family left in a question that may never be answered. What could we have done differently? What could we have done differently? So today, I want to ask another question, not only for young people, but of all us in position of responsibility. What are our governments, our institutions, our development partners, and our leaders doing to ensure that young Africans do not have the risk, they do not have to risk their lives simply to find a future? When young people are willing to risk death in search of opportunity, we must rethink what prevention means. We must rethink not only HIV prevention, we must rethink prevention of despair, prevention of exclusion, prevention of violence, prevention of substance dependence, prevention of misinformation, prevention of avoidable illness, and prevention of the social and economic conditions that leave young people believing that they have no future at home. Young people across Africa may live in very different circumstances. A young woman in Nairobi, a student in Accra, a young entrepreneur in Lagos, a young person in a rural community, a refugee, a migrant, or a young person in Europe may face very different realities. But their aspirations are remarkably similar. They want good health, they want education, they want decent work, they want safety, they want dignity, they want to be cared, and they want the opportunity to build a meaningful future. The United Nations has emphasized that young people everywhere share aspirations for education, decent work, good health, a voice in decisions that affect their lives, and the opportunity to build a better future. Adolescent girls and young women continue to experience a disproportionate burden of HIV in sub-Saharan Africa. Journals reported that in 2024, more than 230,000 adolescent girls and young women aged between 15 to 24 acquired VIH on average of about 570 new infections early every day. HIV prevention cannot be separated from the reality of young people's lives. We cannot simply tell young people to make better choices while ignoring their circumstances in which those choices are made. We must address gender inequality. We must address sexual and gender-based violence. We must address poverty and economic vulnerability. We must address stigma and discrimination. We must address substance use and dependence. We must address misinformation. And we must ensure that young people can access prevention services without fear, shame, or judgment. PrEP and PEP are important tools. WHO recognizes PrEP as an effective HIV prevention option for people at substantial risk, and PrEP and PEP must be made available rapidly following potential exposure. But prevention is not only a pill. Prevention is information. Prevention is education. Prevention is empowerment. Prevention is protection. Prevention is opportunity. And prevention is dignity. This only guess, Africa does not lack resources. Africa does not lack talent. Africa does not lack ideas. What we need is greater urgency, stronger institutions, better investment and leadership that is willing to turn Africa's extraordinary potential into opportunities for its people. We need government that invests in education and skills. We need economy that creates decent jobs. We need health systems that are accessible, affordable, and youth-friendly. We need communities that protect young people from violence and exploitation. We need leaders who take mental health and substance dependence seriously. We need policies that allow young people to participate meaningfully in decisions that affect their lives. And we need development partnerships that invest not only in Africa's problem, but in Africa's potential. The United Nations has similarly emphasized the need for greater investment in education, sexual and reproductive health, decent work, and meaningful youth participation in decision-making. I look forward to seeing this conversation continue, deepen, and translate into action as we move towards ICASA 2027 in Benin Republic. The young people joining us today, I say, your future is Africa's future. Your voice is Africa's voice. And your aspiration must be at the heart of our work. Thank you very much.
You're muted, darling. You're muted.
You are muted. Can you start, Igua?
Yeah. Your remarks remind us that young people are central to Africa's future, yet many still risk dangerous journeys in search of opportunities elsewhere. If prevention is to work, we must also address the conditions shaping their life, including education, employment, security, and access to healthcare. We will now hear from Professor Morenike Oluwatoyin Folayan, a member of the SAR board with extensive experience in HIV prevention and the sexual and reproductive health of adolescents and young people. She will speak to us about youth and PrEP and PEP. Professor, you have the floor.
Thank you very much. I'm going to take excuse from everybody to put off my video because of my bandwidth. And once I'm through, I'll be back on the video. Apologies that you won't see me during this time. But I want to first thank the bodiers for setting this excellent stage for the discussion I want to have. Having set that stage, I'm going to run through my presentation. Hopefully, I should be done within 10 minutes so that we can look forward to the rich discussion that we're going to have here. If there's anything I took away from Luke's bodies piece of work, is that it is time we take our destiny in our hands. If adolescents constitute over 50% of the population in the space, or we are the bulge, we are the majority, don't doubt me that I'm an adolescent or young person. Don't doubt, okay? But if the statistics shows that we are the majority, why aren't we taking the initiative and making our lives better? If we are this rich in Africa, why aren't we driving the forces to come back by the things we do, the advocacy we push? And I hope for that is the major message I would like to share. Let me quickly start. I'm going to do a lot of presentations on the screen, which you will have to read. But otherwise, I'll just speak to what the slide says. Of course, today I welcome every single person from wherever you are, noting that today is the International Youth Day for 2026. And the theme for this year is different contexts, common aspirations. Different context means we are from different countries, different locations within the same countries, different communities, and we all face different pressures. And these aspirations, however, there's a commonality. And I heard Luke say that brilliantly. All we're looking for as young people is dignity, it's opportunity, it's good health, and an assured future where we can thrive. We are not just the tomorrow. We are today to ensure that we create that tomorrow that we want to be. And these statistics might seem audacious. With 37% of new infections still occurring among young people. But we're still, and as I apologize, this is my own area of interest. Adolescent girls and young women are the ones who was affected. Approximately 1 in 5. You might think 1 in 5 is small, but what we're looking at the spectrum of life. Please note that amongst the new infection, we're talking about newborns, we're talking about children, we're talking about adolescents, we're talking about adults and elderly. Within that entire spectrum, adolescent girls and young person accounts for 20% of new infection. That is huge. That is huge. It's not something to overlook. And within sub-Saharan Africa, it is worse for adolescent girls and young women when you compare it to their male counterpart. Thinking, however, that 1.3 billion people below the age of 15 to 24, and the majority are in Africa, the greatest asset that this continent has. So it's not just about statistics there, it's about people, young people, sisters, brothers, friends, and community. And what we're seeing from these figures is that we're having an evolving HIV epidemic, having different faces in different communities, in different settings, with different populations, and with different pressures that we face. For today, our conversation is 3 intersected in 1. It is true I'm supposed to speak about PrEP and PEP, but those are just tools. PrEP and PEP becomes important within the context of our life. And so in these 3 issues with 1 conversation, we're talking about drug addiction, which is challenged by stigma, criminalization, and poor support for persons who are addicted. And what does it mean to prevent HIV when we have the tools in form of PrEP and PEP, and I'll be defining that. And what does it mean when we're talking about behaviors that put us at risk for HIV infection? So why does this 3 conversation have to hold together? Too often, youth-focused HIV prevention programs treat these 3 issues as silos, as separate issues. But in the lives of young people, they all intersect. As a young person struggling with substance use, you will have barriers to accessing PrEP or PEP. Or a young woman who is navigating peer pressure, who doesn't know about PEP. That is an issue. A young person who uses drug and then avoids services because he fears judgment. Yet PEP and PrEP is placed within the facilities. So we're bringing these conversations together because prevention must meet young people in wherever they are in their different contexts. So like I said, I will tell you the difference between PrEP and PEP. PrEP, they're all acronyms. In HIV world, they use a lot of acronyms. PrEP means pre-exposure prophylaxis. PEP means post. The difference is the pre and post. Post-exposure prophylaxis. With PrEP, you take it before HIV exposure, which means you understand your risk, you understand your person, you understand where you are, and you take something to prevent an HIV exposure. However, if for any reason you're exposed, be it through injection drug use or through sex, whatever makes you exposed, you take PEP within 72 hours. You can take it longer than that, but the effective period, if you take it within 72 hours of that exposure. With PrEP, you might take pills or you might take injectables, thanks to the advocates and activists that has brought the long-acting injectable to the table. However, PrEP comes as tablets and you take it continuously for 28 days. So when we're talking about PrEP, we're using it for a long time. As long as we have behaviors that exposes us to risk, we must take PrEP to protect ourselves. However, PrEP, as you see, is like an emergency stroke. There's been an exposure. You just do not want that infection to establish. And so you will take a PrEP. And who's eligible, guys? Anyone at substantial risk, any person, including young persons with multiple sex partners, anybody in serodiscordant relationship. That means one person has HIV, maybe my partner, I'm a female. So if my partner, a male, has HIV, I could use PrEP because maybe we don't want to use condom. Or if I'm condom, as my partner is HIV positive, and doing sexual relationship, the condom burst, then I will go for PrEP immediately as an emergency response. Or if people are using drugs, PrEP and PrEP becomes very important because it's a high-risk behavior. If you are using you're a drug user, injecting drug user, you should be on PrEP to prevent exposure to the sharing of needles. And if for any reason you shared needle, with someone who's likely to have HIV infection, please think about PrEP immediately. Or if there's somebody experiencing gender-based violence, sexual abuse, please get yourself covered by PrEP and PEP, even while we continue to deal with that exposure. Please know that the tools we're talking about is very effective. The problem we have at this time is that very few young people use these drugs. Very, very few people. So that is a concern. And drug addiction among young people is a health issue. And it is deeply connected to the HIV risk we're talking about. Young people who use drugs may face criminalization, discrimination, and exclusion from health services. And therefore, they might be afraid to, use PrEP and PrEP, which is faced with judgment because it is accessible within health facilities. They're not yet outside health facilities. And this is something we also need to address, even as young persons. These are barriers that are known. Like I said, the information, the tools are there. They're all over the place, but very few people know about them. And when they don't know about them, they will take them. The stigma that makes them not go into clinic, there's misinformation about its effectiveness, there's poor access, and there's a cost. Please know that the tools we're talking about, they're free. It's free, but then transport might itself become a barrier. So if there's anything we're hoping to achieve through this program today, it's this 5 objectives. We're creating an open youth center space. That's the dialogue we're going into next. It's just about dialogue. Express yourself. We are hoping that this dialogue will help us improve our understanding of PrEP and PrEP. The understanding is quite low. And not only is it low, the uptake is extremely low. We can only drive the uptake better with improved knowledge. And we want to establish the fact that drug addiction is real and is growing amongst us, but they need to have services that is right place. Please trust the SAR space. SAR is for very pro-young persons, and we're amplifying your voice. It is the more we hear about you, the more that SAR and ICASA can ensure that your prevention message are appropriately tailored to what you want. And please extend the conversation beyond these rooms. You as young persons, me as a young person, we are leaders, leading the way as organization and innovators. We must use and spread the word. My challenge to you today is that just one message following this meeting today on your social media space, just one message will get this message to one more person. And that message, please talk about PrEP and PEP and how to assess this. This is our own social media space, Society for AIDS in Africa. Please continue this conversation. Drop lines for us on Facebook, Instagram, LinkedIn. Watch our YouTubes, share comments. Everything will be unearthed together going forward to ICASA, and we continue to share that message. This is Youth Day, and this is all I created, and I put it on my LinkedIn. This is my own area, integrating care. We cannot continue with the siloed care. You do something and create that space. And this is my call for action. Please learn through the conversation today about PrEP and PEP, and please share with your peer. Ask questions. The dialogue is opening up now. Speak up, share your experience. Ensure and promote support. We are a mass of people that can make change, including demanding for young person service. These are my 6 key messages as I end on the slide. Different contexts, common aspirations. We must make aspirations real. And we are a massive group that can make that happen. PrEP and PEP are accessible. They're effective, but the awareness is just too low. Please create an awareness today with just one message on your social media. Drug addiction is real, and it continues to intersect with HIV risk. We have to help drug addiction issues and raise it in a non-judgmental way to be able to support persons. Those barriers are real. We, as young persons, can break down those barriers by ensuring that our voices are heard, because our voices matter. Please keep the conversations continuing. That's my invitation for you. On that note, I want to say thank you for listening, and once again, note that the space is open to continue this conversation leading to ICASA 2023 that will be happening in the Republic of Benin. Tap me on the shoulders when you see me there. God bless, and over to you.
Thank you, Prof. Polayan, for giving us that important foundation on PrEP, PEP, and the realities young people face when seeking HIV prevention services. We will now move into our studio conversation. For anyone just joining us, this session is being broadcast in English and French. Please go to the chat box and follow the instructions to choose your preferred language. Let me briefly introduce our studio guest. Ms. Shemima Dabla is a nursing graduate and health communicator, passionate about empowering young people through health education and open conversation. She joins us today representing Otarak, our partners for this dialogue. Dr. Nana Kwame Antwi is a medical officer at the Bank Hospital with clinical experience working with people affected by substance use and HIV. He is passionate about preventive medicine and community health. This is a conversation, so please feel free to build on each other's points, agree or respectfully disagree. We have about 20 minutes, so I may jump in occasionally to keep us moving. So let's get into it. In your opinion, what pressure most strongly shape the sexual and health decisions young people make today? Shamima, what's up?
Yes, so I always say one thing. Young people are not just a group of population or a simple population that you can tell what to do. Neither are they a problem that needs to be solved. I think the approach or that narrative needs to be changed, because young people don't just get up and then make the decisions that or behave in a certain way that they behave now. So I think the normal thing that people know here is peer influence, or let me say peer pressure, that everyone knows. Young people constantly would want to engage in sexual intercourse to keep a relationship. Young people are pressured to have sex every now and then to also prove that they belong. And it's not just sex, even when it has to do with substance use. They are pressured every now and then to show that they also belong. And another thing that I'll also talk about is young people love to experiment a lot. And so that is another thing. They are very curious. If you tell a young person, don't do this, trust me, that is exactly what a young person is going to do. So instead of asking or telling them what not to do, I think it's important that we rather create support for them rather than tell them exactly what to do because they are going to do it. And another thing that I also think is the problem here has to do with misinformation. We are in an era where there are a lot of information on social media, and young people are very conversant with social media. They are always there. And so there are people who are not experienced, who are not professionals, giving all manner of informations or putting all manner of informations on social media. And these young people are constantly there reading or getting these information. So another thing I would talk about is this, the misinformation. They are grabbing it from the wrong people. And the right people that young people are supposed to get these information from, they are not comfortable. Nobody judges you on social media. Nobody knows what you are viewing on social media. For instance, if you're on social media, even watching pornographic movie, nobody knows what you're doing over there. It's not regulated. So they tend to be misinformed a lot. So peer pressure, misinformation. And another thing I would also go in for has to do with confidentiality. Young people do not trust easily. So they find it difficult believing in what you're even telling them. And here is the case. Most people don't even approach young people the right way because we tend to put fear in them. And that's what young people do not want. The moment you're trying to educate a young person and you put fear in them, exactly what you're telling them not to do is what they are going to do. So I think it's the peer pressure, the misinformation, and then the lack of confidentiality here.
Dr. Anchi, would you like to share another perspective?
Yeah, no, so I agree with everything she said. Majority of our adolescents and young people, our frontal lobe is developing on a daily. Science says not until 26 do we have our frontal lobes fully developed. So it makes risk taking more likely when it comes to young people. There's also always impulsive decision making, and sometimes it ends up in the wrong decision to be made. There's also the social media aspect that she mentioned, where there's so much information online these days. TikTok is amazing. So many different information to digest. And sometimes when you hear the things that people are taking in, it makes you wonder how the world is going to correct some of these challenges. So these are some of the things, peer pressure as well. When you put yourself in a room where everyone is doing the same things, you feel compelled to copy and do the same things that is being done, even to your detriment. And these are some of the challenges that affect young people.
So I would like to follow up with what she said. She mentioned that we can get misinformation on social media, but what is the way forward? Should the government put like a barrier to who can spread that information? Like should it be health practitioners? Should it be only people living with a certain condition or people with experience? Because once we start going towards that conversation, it's still the same limiting them. So it's like you have freedom to go on social media, say what you want, do what you want. But at the same time, should we also limit social media to just the health professionals? What do you think?
If you ask me, I do not think social media should be limited to just the health professionals. It's not a health space. Social media comes with a lot of things. So depending on what your interest is what you are going to share on social media. But what I think we can do here is, what is the underlying cause of this? I said earlier on that young people do not feel confident, or let's say confidential enough to look. They know where to get this information from, but the environment is just not safe for them. And so they prefer to just pick their phones and go on social media to go and get that information because nobody's judging them over there. Nobody knows what they are searching. assuming a young person even decides to have unprotected sex, they know that they can go to the nearest clinic the nearest clinic to their public health unit and get help from there. But it has to do with fear of being judged. So they prefer to go on their phone. And that is where the misinformation comes. Instead of a young person going to the health facility to seek for care or advice or even HIV services, they would rather pick their phone to read from different sites. So I would say that we cannot just limit social media to health professionals, but health professionals need to be maybe given extra training where they would find a way to make these young ones very comfortable, because the environment isn't safe for them. They feel you are going to judge them. And let's be honest, I'm a health person, and if we all want to be open here, sometimes young people come to the facility, and sometimes the questions we ask them, sometimes we ask the questions and they know very well that you are judging them. That is not what health professionals are supposed to be there for. Regardless of what the situation is, we are there to support, we are there to encourage, we are there to provide services. And so the problem is from health professionals. If we can be confidential enough, if we can keep the space safe for these young ones, trust me, they will come to us for the information rather than go to social media and listen to anybody that decides to share myth on social media. So we need to do better as health professionals.
Agreed. So at the end, it all boils down to destigmatization and supporting.
All right.
Now, that will lead us to our next topic. How does drug use affect sexual decision making, consent, and vulnerability to HIV? Dr. Nchiku.
Yeah, so I mean, drugs and alcohol, they reduce your capacity to fully process risk, especially when you're in situations that there are needles and sometimes you have coercion and things involved. So once there's always drug and alcohol use, there's always that inability to fully process the situation at hand and fully assess the risk involved as well. So it impairs brain capacity to fully understand the risk involved. In certain cases, too, if you are in situations or in a room, let's say you're at a party where everybody is doing drugs, everybody is drinking alcohol, sometimes you're compelled to do the same things you're doing. And in certain cases, some people are even coerced into doing things they've never done before. And this would drive some of these challenges to where drugs now become a driving factor for HIV exposure because of these things. So coercion, peer pressure, being alcohol and drugs already sort of limits your ability to fully process things that are around you, going on around you, and fully assess the risk as well. So that's how drugs become a very important role in HIV prevention.
Shamima, does that reflect what young people experience, or would you like to add?
Yes, absolutely. I think I would like to add up to what Dr. Entry said. So, look, let's be honest. As is it Morenike?
Yes.
Mentioned, pardon me, as Professor Morenike mentioned earlier on, you can't even have a conversation about HIV or sexuality without substance abuse or addiction, because it goes hand in hand, if you ask me. And I always say this, when it comes to addiction or substance use, it's very much related to HIV risk, or let's say it's influenced by HIV risk in a way. Because let me start with directly, how this can happen directly. So as Prof said, people are now injecting these drugs. It goes beyond smoking and taking these pills. Now they are injecting them. So they tend to share needles. They tend to share syringes. And then indirectly, as Dr. Entry said, it impairs your sense of reasoning. And what happens here is that it can lead to condomless sex. because you are not in the right frame of mind. Once you are intoxicated, you are being controlled by the substance. That could lead you to condomless sex, as I said earlier on. It could lead to another thing. Once you're on these substances, it tends to alter your libido. So your libido becomes higher than usual. So you tend to want or different people, or it basically leads you to having multiple sexual partners. And so what it means is that you are going to be involved sexually with all these people, which is a very high risk when it comes to HIV. Another thing here is you are not in the right frame of mind to negotiate safe sex. Anything goes. Because if you're in the right frame of mind, you're able to say that, okay, let's use a condom, or even no. But here's the case, you're on substances that is altering your libido. You even want it. You are even going in for it. So there's no way to protect yourself in terms of this. So I totally agree with him.
It's a very, very valid take as well. I would like to direct this question to Professor Morenike, as she's online. Professor Morenike?
Maybe she's gone off.
Professor Morenike, I want to ask, what do you think the biggest barrier to PrEP and PEP uptake among young people, and what can make access easier?
Oh, you want me to come back on that?
Yes, so I would just like to ask your opinion on what is the biggest barrier to the PrEP and PEP.
Yeah.
What would make the access easier?
I'm going to be a lot theoretical, but I'll share with you what I think. I want to put on my video so that we can say what I think are the barriers. One, I think we've used models that are not appropriate for our context. We have, we hear what people are doing from the global north. Remember what the team is. It has to be context. We truly don't know what our context is. We see we are how many years into the epidemic, and yes, this is PrEP, this is PEP. Only less than 10% of the population know, are aware, are using, where they feel they otherwise should use. I think it's because we haven't developed models, and this is the challenge. I think because I responded to some of the questions in the chat box, that the youth population is too enormous for us not to put pressure for change and ask that our local researchers, this is what you should be doing. What is our context? So don't do this kind of research that has no application to us. This is our lives. This is real. These things are there. We don't even know it. Without us knowing, we won't even access it. Even when we know it, it doesn't translate to access. What are you studying in your research to help us understand context and how we can do it better? That's the first thing. Second is that health service within our region is too much dependent on facility-based. We're not facility-based people. We go to the hospitals because we want cure. Whereas PrEP and PEP are prevention tools. We don't normally go to the hospitals for a checkup. Least so adolescents, and this is a known parameter. So why are we putting these essential tools for communities and adolescents in the facilities that are not youth friendly? These are, for me, apologies, I'm not answering your questions, but this for me are questions about the barriers that we know exist and yet we're not addressing. It's too far long. By 2030, HIV is out of the plate for many people, but it's still real for Africa. But it's not just real for Africa. Once it is out of the plate, we're already seeing it, an escalation of the HIV epidemic. So the questions, the barriers are real. Access is a barrier. Knowledge is a barrier. But how to change that paradigm? That barrier is not 10 years old. It's 20, 25, 30 years, 50 years old. Why are we still saying the same story? The same story I told my child who already has a grandchild, So for me, I think that's the driver. Context specific. It's everything is context specific. What are we doing to understand that context, to change the barrier? And we as adolescents must ask. We as young persons must ask. We're not asking. If we ask, they will change. It will change in paradigm of what we're currently doing. Apologies, but I don't know if it answers your question, but this is my this is my sentiment about what is happening on the field. Thank you. Over.
Thank you so much for that insight, Professor Morenike. So the next question I would like to ask Dr. Anchi, can we genuinely rethink HIV prevention for young people without addressing the stigma from healthcare providers?
No, it's not possible. If you want to reduce the HIV prevention, we definitely have to individualize it and then talk about stigma as well. That's the only way we can move forward in HIV prevention. Stigma is a big role in this condition that we are talking about. Youth are not able to come and tackle the right areas. They're not able to access the right information because they're afraid of being judged or being untreated fairly. And imagine a young person who has some exposure to HIV and doesn't know where to go because he feels like if he goes to the parents, they are going to judge him, or if he goes to the hospital, he's going to be judged. And so what does he do? He ends up going online, and then so we need to address stigma. Stigma is the main thing when it comes to HIV prevention. Once we are able to put in measures, whether it's community-centered measures, in order to get the youth to be able to come without feeling pressure from the society, maybe we can open up different clinics to the usual adult clinic where they can come in and meet health-friendly, health and technical people that can ensure that their addresses are their address is concerned. Yes, exactly. And so the stigma part is very much a big role to play in this. Very much.
Shemima, well, how does that compare with what young people actually experience?
So, I will keep repeating some of the things. If there's one thing that young people always experience, it has to do with the judgments. So we are talking about stigmatization with regards to healthcare providers. I will keep saying this over and over. The environment is not safe enough for them. And if we want to take that out, it will almost be impossible because they are facing, and let's just say a young person is not just navigating the medical risk of HIV. They are navigating the risk of fear, judgment, lack of confidentiality, access to these services. And so if a healthcare provider, on the other hand, is a bit judgmental or discriminates against them. Look, there are instances where even a young person walks up to a facility to get maybe services on contraceptive. And sometimes you hear these healthcare professionals asking them, hey, what are you doing here? I don't think that is what they need. You are there to receive them, to offer those services to them. So I don't think, if you ask me, it's not welcoming enough to ask, hey, even the tone, hey, what are you doing here? So the welcome alone feels like fear. And whatever reason they are there for, trust me, a young person will not open up. And once it happens that way, we will make headway because, like I said earlier on, you can't tell young people what to do. You can only support them. So yeah, that's it.
Thank you both. That was an honest and practical conversation. We have heard that young people's choices do not happen in isolation. Social pressures, drug use, access to PrEP and PEP, and their experiences with healthcare providers all shape HIV prevention. Oh, please, I would like to invite Professor Morenike.
Thanks for giving me the space. I'll be very brief. I heard very excellently about stigma. I heard very excellently about what it means. But I'm also back to this context. Our life in Africa and the way we communicate is stigmatizing. It's just like that's so without It's a fundamental. It's not just HIV, it's a fundamental. We stigmatize. There's always a gay. We're always better, we're always judging. And one of the things that I was studying very recently in a space is that, look, when you're talking about young persons, in the African context, go check it. There's only two groups of people, children and adults. We don't understand youth in our context. Our African context moves us from children through the peer pressure into adults. So all of a sudden, HIV has brought a unique group, young persons. Despite all the training, they would always think of a young person as a child. Must be protected. And why are you here? Even when you're 22, until you're married, you're just. So there's that cultural context making us not give the respect needed to deal with adolescents and young persons. We haven't dealt with that. This is all about that adoption of a system that hasn't adapted itself into the context. And finally, let me talk about that communication, the brilliant communication our journalist here shared with us. Even that same communication that you're talking to young person is the same way that they speak rudely to adults. Why are you here? Look, please, leave it's the same bad way. It's just that young persons are a lot more sensitive. So that communication strategy has to be part of the training of everyone. We don't have it. We're just trained on how to do there's a doctor there. This communication in our training as doctors, it doesn't exist. So we don't communicate effectively, least so to the sensitive people. There's a whole paradigm that has to change. I'm thinking going forward. Does this whole paradigm, can it change in 2 years, 3 years? I don't think so. But we must start and get people to respond and start to think about it, and slowly we would get to where we're going. Too slow. We should have started 50 years ago, but we have to start. Thank you. Over.
Thank you, Professor Marinike. Yeah. We'll now take questions from audience. If you have a question, please type it into the chat box. We'll also use the raise hand function, and our technical team will invite you to unmute, and you can ask your question live.
I think we can.
Questions are welcome in English or French. If you have just joined us, please go to the chat box and follow the instructions to choose your preferred language. Please keep your questions brief. Tell us your name and let us know which speaker you would like them to answer the question.
I think we can join now. Well,
You can see them.
they're showing it.
Medicine.
Mhm.
Okay. Someone asked, what skills and experiences should young social work and community development professionals develop to build careers in HIV and youth-focused programming?
What's the question?
Oh, you wanted me to answer? Okay. Because I see you looking up. Yeah. I could just.
The audience questions. Let me ask one final question. What is the one thing every young person should understand about PrEP and PEP?
It's available. It's effective and available. If that's the one sentence I have to say, it's effective, it's available. Why have I emphasized that? It's the same thing with contraceptives. It's available and effective, but young people are scared because of the misinformation around the symptoms and all that. So that might be the thing we're also dealing with PEP and PEP. It's available, it's effective, but there's misinformation about maybe one person had side effect and then 50 people, 1,000 people are telling the story of one person as if that is the norm. So one message, it's available. Learn about it, ask questions about it. And if you find it relevant for you, please take it, especially PEP. It's like an emergency truck. Anything can happen. Once you wake up the next morning, you were on drugs yesterday night, now you're remembering and recollecting, go get your PEP. Go get it. It's about my and your life. Yeah, thank you.
Thank you. So someone said, I have seen different models and approaches introduced towards effective SRHR programming come and fail. What could be the cause?
I don't know what the cost is. I'm not a magician to be in that space. I can assure you, if there's a guess, if you offer me $50,000 and ask me to make one single guess, my guess would be that the poor adoption of the model. Okay? Because models have to be adapted, and the way you use it, for example, if it's designed by human-centered design, you're supposed to be adapting. You're not supposed to wait after 2-3 years and find that it failed. You start it now, you keep adapting, and in that adapting, you know what works, which means you're reviewing every 3-6 months, and you're learning and you're adapting. Those kind of models don't fail. Because if you adopt a model now, 3 years time down the line before you take your parameters and then it fails, of course it's failed, but you wasted 3 years of not learning. You've only learned what it fails. So if I have to answer the question, I think it's adaptation. And what I am not seeing us do well is getting our researchers into the space. I completely celebrate Look at this point. There's so much that SAR and ICASA wants to do around researchers. Do this research not just for promotion, do this for the lives of people. This question is the question for researchers. Why is it failing? Why are you in this space? What are you doing to adapt it appropriately? We need to challenge our researchers to do more things that are relevant for us rather than looking for grants and addressing things on the global north. Apologies, I come with a lot of sentiments. Over.
So much. So I will address this question to Shemima. The person said, in your opinion, what is one practical way we can bring PrEP and PEP closer to the young people in their communities?
So it is very simple. It is high time we stop seeing young people as audience when it comes to HIV prevention. We have to start seeing them as co-designers. So this is where we move from designing programs for young people to designing programs with young people. And so instead of just telling them to go for the information, sit down for long HIV prevention lectures, why not involve these people in the implementation of programs or designing of programs? Because the only way this can happen is once they are involved, they are making a decision. Trust me, they are the same people that are even going to go out there and spread the word. We wouldn't have to go through all the struggles we are going through to let people understand that, okay, HIV prevention starts from testing to prevention to the PrEP to the PEP. Once young people are involved, trust me, they'll be the ones spreading the word among themselves instead of us. So all I'm trying to say is, let's get them involved. They shouldn't be audience anymore. They should be part of the implementation plan.
Thank you very much. I think you also answered the last person's questions. They said, how can organizations meaningfully engage young people in designing and implementing HIV?
Basically.
You already talked about it. So I'm going to ask Dr. Antwi, you can just let them know, how many hours do people have post-exposure to take I'm sure they meant PEP, because PEP is quick.
So you have about 72 hours after exposure. So within the time of exposure to 72 hours, you can take the pill, which is a daily pill for the next 28 days.
Thank you.
Can I add something?
Yes.
Yes, just to add up to what Dr. Antwi said. So one thing about PEP is very time sensitive. That's one thing we should know. So within the space of 24 hours, it shouldn't be later than 72 hours. If you feel you have been exposed, there is no time to say, oh, let me think about it if I should go to the facility for help. You do not have time. So the moment you feel you are exposed, please, within the space of 24 hours to the 72 hours, seek for help.
The earlier, the better.
The earlier, the better.
Thank you so much for your questions, and to all our speakers for their contributions. Today, we have heard that effective HIV prevention for young people must respond to their realities, provide accurate information, and ensure accessible, non-judgmental services. On behalf of the Society for AIDS in Africa, I want to thank our speakers, the Rotaract, our technical team, and everyone who joined us. Follow us, SA and ICASA, on LinkedIn, Instagram, Facebook, X, and YouTube at SAAFRICA, that's South Africa, or ICASA, ICASA. And you can also follow us for any updates on programs. We have a few upcoming webinars, so make sure you stay tuned. Happy International Youth Day, and thank you all.